All right, so welcome everybody. I'm Richard Lebert. I'm going to do a bit of a talk on peripheral neuropathies or peripheral entrapments, what they are, a little bit of detail about them. I'm going to go over some common and uncommon ones, and then just some clinical experience stuff of things that kind of have worked for me in the past. Okay, so when we go quick, okay, a quick refresher for the anatomy of the nervous system. You know, you'll have the central nervous system, you'll have the peripheral nervous system, you're going to have the sensory and motor divisions that come off it. Sometimes the nerves will be mixed, sometimes they'll be a purely sensory nerve, sometimes they'll be a purely motor nerve. And then within the motor nerve, you remember there's going to be autonomic functions as well. So sometimes that's some of the more subtle signs of a peripheral nerve entrapment is people are having autonomic dysfunction in one specific area. So you can think about some of the signs would be redness, a bit of a tissue swelling. They may even have some increased sweating or decreased sweating. And sometimes they have a bit of a shine or a discoloration of their skin. They may also have like lack of hair growth in a certain area. So sometimes that's these little subtle changes that you may find, even if there's not giant like muscle atrophy or other issues going on. So again, we think about peripheral nerves. One will have the cranial nerves, and sometimes a lot of those are outside of our scope, or some of the issues may be very hard to pick up on. So I'm not going to spend that much time on it. But then when we talk about like the spinal nerves and then the major plexuses, so brachial plexus, lumbosacral plexus, we're going to talk about some of the entrapments of the nerves coming off those. So when I'm talking about peripheral neuropathy, I'm just using it as a very broad definition to cover irritation. So if it's like a nerve inflammation or a true compressive injury of a peripheral nerve, and then like what we learn in school. So there could be muscle atrophy, there could be sensory loss where there's no sensation, there could be mild numbness and tingling, or sometimes subtle autonomic changes in the nerve, in the supplied area. So the entrapments can happen in a number of places. So when I'm going through some of the common entrapments, remember that just might be one entrapment sites, because you know there's the double crush injuries, triple, like nerves can be irritated by so many different structures. They can be irritated by where they pierce through the skin, where they pierce through the fascia, where they travel alongside of a bone, or even they're just irritated by an inflammatory response from friction created over time. So nerve entrapments can happen in a number of places. So I'll go through like common entrapment sites, but remember that's not going to cover everything. So neurogenic inflammation is one of the biggest things that may cause neuropathy, even if there's not a true compression of a nerve. And so when we talk about neurogenic inflammation, one, we can talk about the, let me get my highlighter here. One, we can talk about when there's like the peripheral site of entrapment. So say it's a true, for example, say a true carpal tunnel syndrome where there's an entrapment, there's going to be inflammatory response at that area. As that inflammatory response goes on and on, there'll be changes at the dorsal root ganglion. And so we'll touch on that a little bit later. But what that may do is spread out. So it's called extraterritorial spread. So it may spread out the symptoms to a wider area than just say the entrapment site of a median nerve. Sensitization can continue, say it's been going on for 6 months, it's been going on for a year, and what you may get is changes at the spinal cord level. So glial activation, you get sensitization, and then that can continue up to the level of the central nervous system and the brain. So you may have sensory motor changes, and it may spread out to other areas of the body that are overlapped in that sensory motor area. So that may explain people have carpal tunnel syndrome going on for quite a while, and it may spread out to other areas of the body. That can somebody mute the Facebook recording in the background? People have carpal tunnel syndrome going on for quite a while, and it may spread out to other areas of the body. That 1 second. There, might be done. Okay, so it might spread out. So you think about the example where somebody's had carpal tunnel symptoms of carpal tunnel syndrome in one hand. It's been going on for 6 months to a year, and then they start developing symptoms in the other hand. There's a possibility, say maybe occupational issues or whatever, that it could be a true compression in both sides. But what may be going on is there's been some reorganization in the sensory motor function in the brain. And so it recognizes symptoms, or it starts treating that other hand like there's symptoms going on as well due to the neurogenic inflammation. So there's lots going on, and it's not a pure entrapment. There's going to be issues going on in the spinal cord, issues going on in the brain, like neuroplastic changes, which is bad for an injury. But when we think about it from a recovery phase, it's a good thing, because sometimes these kind of non-invasive approaches may work if it's more just you have to work with kind of sensory motor re-education. So neuroplasticity, should all kind of be familiar with it, but it's just the body's ability to repair itself or respond to an injury. But the body always has an inherent ability to respond positively to an injury, right? Some may take longer depending on the severity of the injury or age, but the body throughout the lifespan has that inherent neuroplasticity. So bioplasticity, kind of like a rip off of that neuroplasticity term, but meaning that there can be changes in the body go on as well that may be reversed by, you could think about manual therapy, exercise, or any intervention may reverse some changes going on in the body. One really good example you can think about is neurofibrosis that can develop around a peripheral nerve, the connective tissue of a peripheral nerve. And there's been some really good research by Jeffrey Bove in it is modeled studies, so it's in rats, but to say these rats are exposed to a repetitive stress and then treated with manual therapy, just gentle stretching of the limbs, and that helps decrease the buildup of these this neurofibrosis. So we think about there's going to be an entrapment. There also could be neurofibrosis as well with that. So even just gentle stretching, gentle manual therapy was able to reverse some of the buildup of neurofibrosis. So what I'm going to go through next is some assessment techniques, very basic techniques. We're not going to go into very deep detail, but we're going to go through some things that often get overlooked. And just do a quick check of the chat, see if there's been anything. Okay. All right, so when we're doing an assessment, we think about assessing motor, sensory, and reflex. That's kind of like our base. We're doing Tinels, which can just be gentle tapping over the nerve. So common that we learn Tinels over the median nerve. but also useful for the ulnar nerve, radial nerve, over the brachial plexus, over lateral femoral cutaneous nerves, a lot of different sites where just light tapping of the nerve to see and compare it side to side to see if you're going to elicit a sensory response. So in these images, just a couple different spots that for the median nerve, lost it. Couple of different spots for the median nerve that you can tap, a couple different spots for the radial nerve, and a couple of different spots for the ulnar nerve. And then we talk about neurodynamic testing. So we have the upper limb tension test 1 and 2, which are mainly median nerve. And then you'll have the 3, which is for the radial nerve, and 4 for the ulnar nerve. And then you'll have sacral nerve testing as well. And then some other orthopedic tests. We think about Phelan's, we think about extended arm test, and then we'll go through a couple examples. So one of the tricky things with dermatomal testing is most resources list a different innervated area. So I don't think there's that it's a very precise thing all the time. You may have overlap, you may have overlap of innervated areas, you may have symptoms that are spreading out to different areas, but just as a rough guide, there's been a research study, I forget the exact name of it, but if you look it up, it's Lee et al. 2008 it was published. And so what they did was to look at all the available resources and see what the overlap was and what maybe would be the most evidence-based dermatome map. And this is what they came up with, is that it's fairly similar to a lot of different maps, but you can see how there is kind of shapes to each distribution, especially in the back. So you can see how it's not going to be textbook and it's not going to be standard person to person. Like symptoms don't always follow a standard pattern. This is from a study done quite a while ago, and there's been reproduced studies, but the phenomenon of extraterritorial spread, where a chronic nerve compression can cause an immune or an inflammatory response at the dorsal root ganglion, at the spinal cord, and at the brain. And then you're going to have symptoms that are spread out further than just the distribution at a D1 peripheral nerve that's entrapped. So when you're assessing myotomes, that's a little easier to say, oh, these are the things we're testing, than the dermatomes. Dermatomes is just spread out a lot, and you are innervating lots of different sensory tissues. And so that overlap is wide. For muscles, it's a little more straightforward. So we think about C4, shoulder shrug. C5 still going to be a bit with the shoulders, but you're going to have a little bit of movement at the elbow. C5, wrist extension. C7, elbow extension, wrist flexion. We've seen all this in school. It's the slide. I'll make the slides available. I'll post it on SlideShare, and I can give the link to Mark throughout the day, and he'll post if he's doing a follow-up. But this is a really good slide to, even if you want to screenshot it right now or print it off, it's just that myotomal assessment. So deep tendon reflex, we don't have to be super detailed with this. If there's issues, you can always refer them off, but for sure, have that availability to do like a biceps, deep tendon reflex, brachioradialis, and triceps for the upper body. Those 3, and you might be, you have that. For the upper body assessment, we think about special testings, Sperlings, if we're going to look at like radiculopathy, Valsalva's, if there's going to be a disc issue or a bulging disc that's causing spinal cord irritation. We have the upper limb tension test, and then we'll have some of our TOS testing, and Phalen's as well. Lower body slump is your good go-to. So if people may be a little sensitive with the slumps, but slump, sit in a bad posture and extend the leg and see if they're getting symptoms with that. And then notchless, so that's going to test for the femoral nerve. And then straight leg raise is going to be the sciatic nerve. And then you can be a little specific with how you're going to position the ankle. And you can test tibial, peroneal, and the sural nerve as well. Today, just because one, it's a PowerPoint presentation, and two, it's just a very short, we won't have time to go into the specifics of the assessments, but just kind of a refresher of things that you can be kind of look up and be aware of. Deep tendon reflex, it's simple. So you say the easy to do knee deep tendon reflex, the one at the Achilles, and then to see if there is a true kind of upper motor neuron disorder, you could do like the plantar reflex. Remember the Babinski sign. Okay, so now we're going to get into the entrapments. We're going to get into entrapment sites and kind of certain injuries that really have shown to respond well from massage therapy. So the treatment of a peripheral nerve entrapment can depend on what's causing it. So how well will somebody fare and how good the recovery will be. It depends on what's causing it, right? So if somebody has a neuroma or growth around the tumor, or a tumor or growth around the peripheral nerve, it may not respond that well to manual therapy, and that's where it may be nice to refer out to a surgeon or their primary care physician to look into that a little bit more. There's also car accident, knife wounds, old sports injuries that can cause like ongoing nerve entrapments. And then there could be like stuff related to pregnancy or diabetes, right? So lots of different causes of entrapments. We're going to go, stuff we're talking about today is a little bit more of like a repetitive strain or just an entrapment from a more basic musculoskeletal cause. What's really interesting is old books, old manual therapy books or physical therapy books talk a lot about treating nerves. One very interesting person who talked about, so the therapist's name is Henrik Kellgren, but in the early 1800s, mid 1800s, he talked a lot about treating peripheral nerves. So none of this is new, but it kind of was not really popular for a while, and then now you see a bit of a resurgence where it is popular again. So safety considerations, always treat upon with the agreed upon pain tolerance. That being said, maybe even go, especially if you're treating a true entrapment, go a little bit easier because people might have a flare up of symptoms right after treatment, and it can be intense at sometimes. Same thing with if you're giving them nerve mobilization exercises, say start low, go slow, and then build it up week after week. Because when you're working with the nerves, is you can get a big flare up the next day if you're too aggressive. So sub-occipital neuralgia, you'll have the sub-occipital nerves. They can be entrapped generally by the sub-occipital muscles. And what that presents like, you'll see these red, blue zones. It's just the entrapment of different cutaneous nerves, but you'll just have symptoms as it travels along the back of the head. Them sleeping on a pillow might irritate it, like if they're laying on their back. So what I generally do for treatment like this is just gentle sub-occipital work, and I'll work up along the back of the head as well, and I'll work along the C-spine as well. And it's just monitoring, treating really light at first, and then you can compress, or you can move up to a little bit more pressure, but just doing some light work of the suboccipital area and see how they respond. And then you can increase pressure as you go along, working some nice stretching of the suboccipitals. There's a couple nerves, supratrochlear, supraorbital nerves. Sometimes they'll get Botox injections when people have ongoing headaches. So even just light work, what we would do already, but just light work above the eyebrows to the forehead can be really, really good for these little superficial nerve entrapments. So axillary neuropathy. So the axillary nerve, it will innervate the deltoid muscles. And so what you can get is an entrapment, see, as it pierces through the infraspinatus and the teres here. So you get the nerve travels right through that little spot, right? So just gently working the rotator cuff, adding kind of internal rotation, range of motion with that. And that can be really good for that entrapment. People might be a little sensitive, but think about this with anybody who's had a rotator cuff surgery in the past, or if they've had torn rotator cuffs, this can be a really good area to work for somebody. Suprascapular nerve neuropathy, another one that goes along with rotator cuff injuries. So when we think about two different sites that it can be entrapped, one right here, if the infraspinatus, and a lot of people have infraspinatus tears and may not even know it, but if you get an infraspinatus tear, it might entrap or irritate the nerve right in there underneath the spine of the scapula. The other entrapment site is a ligament that travels across the transverse scapular ligament in the suprascapular notch area, and the nerve can be irritated in two of those sites. So think about stretching out area of the supraspinatus and area of the infraspinatus. Here's an interesting one and a really relevant one to practice that we don't always think about, but people often have that aching, sometimes even sharp shooting rhomboid pain, right? And so we treat the rhomboid, always working on the rhomboid, stretch them out, work at them, get a ball in there and work it. But also be aware that the dorsal scapular nerve travels right under there and right along the shoulder blade. So maybe sometimes when people have that really burning, aching, numb, tingling back pain, it might be an entrapment of the dorsal scapular nerve. So maybe it involves a little bit of a gentler approach where you're doing like some nice active free range of motion exercises with them and not having them dig in with a tennis ball. Some people get relief from the tennis ball. For that population, tennis ball is fine. But for people who are, I'm going at this spot and it's getting worse, think about if there's a possible nerve entrapment. Long thoracic neuropathy. So we think about long thoracic nerve, how it innervates the serratus anterior. You get entrapment there. It could happen with the posterior scalenes. You can get entrapment with any of the scaling muscles because it's tied in with the brachial plexus. And then you can see how the pec minor as well can irritate that nerve. But when you think about it, that telltale sign, so we're looking for winging of the scapula, and generally it might only be one side. So this site is going to take a lot longer to respond to treatment, and sometimes it's like a very complex with lots of different practitioners involved. But just be aware, you're looking for the winging of the scapula. This is a nerve that it's kind of a more rare entrapment, but a good to know about entrapment. Carpal tunnel syndrome, everybody's seen cases of carpal tunnel syndrome. Everybody's seen different cases where somebody has really bad symptoms, somebody has minor symptoms. There was a really good research, and it's actually been repeated. They had an early research, and then they tried another trial again. And This is Fernandez de la Peña, probably butchered the name, but the research was published in the journal JOSPT, Journal of Orthopedics and Sport Physical Therapy. And what they found is that for a majority of patients, there's no significant difference at a 12-month follow-up, whether they have manual therapy or they have surgery. So you see after so quality of life. So you even see the manual therapy group in the healing time of 12 months actually had really good, compared to the surgery, really good outcomes. And then at the 12-month time post-surgical, they had similar outcomes. So for mild to moderate cases of carpal tunnel syndrome, manual therapy, massage therapy, working the neck, like a comprehensive treatment, working the neck, working the forearms, it's going to be great for the patients, right? Thoracic outlet syndrome can be a little more complicated because there can be vascular issues as well. The entrapments, people may not respond great to massage therapy. In some cases, they may. So it's always worth a trial of 4 to 5 treatments, see if it improves a little bit, makes no difference, or if it gets worse. So thoracic outlet syndrome, in my experience, I haven't had great results with it. But when people have minor, say it's very minor symptoms where they wake up with numbness and tingling, massage therapy can be great. When they have that really really severe entrapment where there's vascular issues, there's discoloration in the hand, there's coldness to the hand at all times, for sure it's good to work with their primary care physician. Cubital tunnel syndrome, there's lots of different areas that the ulnar nerve can become entrapped. And so remember, we're working along that whole distribution. We work around the carpal bones because it could be entrapment, the tunnel of Guyon, entrapment along the cubital tunnel. So the ulnar nerve, there's lots of different areas for entrapment. So I do a shotgun approach where I'm going to work the whole arm. I'm going to work the upper limb as well. Lateral epicondylitis, we generally think of it as a overuse tendinopathy, but there's also the radial nerve that travels along that distribution site as well. So think about the radial nerve being entrapped, and that might cause some of these symptoms of tennis elbow. So when you have an entrapped nerve, you might have the tendon changes and the muscle changes going along with that overuse injury, and that's irritating the radial nerve. Here's a good example that I like. This was a study, and I did not post the link to it, and I'll blank on the author's name, but a really good study where they found that they would do a lidocaine injection into the kind of base of the thumb, that area. In acupuncture, it's called Li4. And so what they did was an injection there, and it cleared up a lot of their pain, numbness, and tingling on the ulnar distribution. And what they did eventually was MRI findings to find the distribution of the ulnar nerve reached over to the other side of the body, the other side of the hand. So think about that. Yeah, you're going to have the ulnar distribution in the ulnar side, but you're going to have little branches of that nerve that's going to go across across the whole hand. Because what the body's done over time is built in a lot of redundancy. So if you have an entrapped nerve, if you have a lot going on, you can have areas of the body that can adapt and take over for certain functions, right? So you're going to have a lot of nerves that overlap because it's built-in redundancy in the body. So lumbar radiculopathy, kind of one of the most common things, nerve injuries that we would see in practice would be kind of like a sciatic nerve entrapment or a bulged disc in the lumbar spine, where it's that L4, L5, symptoms going down the legs, symptoms going to the foot. Be aware of the straight leg raise as the assessment. Like, people may be sensitive with it, but think about the straight leg raise or slump testing as treatment as well. So you can back it off from being too intense and just doing a bit of repetitive motions at the ankle or nice flossing at the neck to help do some nerve flossing to help mobilize that nerve a little bit. Here's a good example. So I use this in slides a lot when I'm doing presentations. So there's Otzi the Iceman was maybe you've heard about it. National Geographic has covered this case a lot. So it was a Iceman discovered in the Alps. It's over 5,000 years old. But the interesting thing with it is that it had like tattooing all over the body. And they found that it overlapped with a lot of different acupuncture points, right? And myofascial trigger points. And so when they did MRI imaging of this body, they found that a lot of the tattoo sites overlapped with the peripheral nerves, especially the sciatic nerve. So they're thinking about that maybe they were doing the tattooing for a therapeutic purpose because they had low back pain, they had nerve entrapments. And so some of these sites are very old when we're talking about acupuncture points and trigger points, because it's where people would get pain or therapeutic benefit, because it's where you can access or have instant access to like a nerve. So that's just an interesting thing and a historical thing that I add into slides most of the time. But when we think about it, so you'll have the spinal nerves and what they get. So spine, then you'll have spinal nerves, and they go right out to that area of the low back. So access to the spinal nerves. So if you're doing acupuncture, if you're doing massage, you're stimulating that nerve. And so that might be a way to gate that nociceptive response going up the body, right? Cluneal nerves, one that we don't hear about a lot, but when you look at them, they may explain a lot of SI joint pain. So they come off the sacrum, they come off the low back, and they'll innervate. It's more of a cutaneous nerve. And so entrapment or even inflamed tissues at that area may cause a lot of SI joint pain, right? So in these patients, doing gentle stretching, maybe not overworking the area, because if you already have an inflamed nerve and you're just getting your elbow right in on there, it can irritate these nerves. So always think about, there could be a nerve entrapment and how you could manage it. So if you're just using gentle heat, if you're doing gentle kind of mobilizations at the joint mobilizations at the hips, if you're doing some stretching of the hips, all that to help kind of decompress that nerve. Yeah, we don't have enough time to touch on these today, but be aware, even for a lot of abdominal issues and hip issues, there's lots of entrapments coming off the lumbar plexus and coming off the sacral plexus. So always be aware, like, people have numbness and tingling, especially into their groin area. Think about, might not be stuff we're treating, but think about if there is an entrapment there, or if there's like a disc issue or a bulging disc that's causing or contributing to that. Femoral nerve, always a good one to be aware of, especially post-surgical knees, or people who have had knee surgery or hip surgery. If it's a full hip replacement, full knee replacement, or even just an ACL repair, you can get entrapment of the saphenous nerve, and especially this infrapatellar branch of the saphenous nerve. And just doing some light sideline stretching where you're extending the leg back can be very beneficial. Even just working that whole adductor area, very beneficial for femoral nerve entrapments issues. lateral cutaneous nerve of the thigh, lateral femoral cutaneous nerve is, they don't have the full picture here, but it's the one we learn about in school, right? So people wearing skinny jeans, people putting their belts too tight, people doing hip thrusters where they're putting an Olympic bar across their thigh may entrap this peripheral nerve. And that can look like numbness, tingling just down that lateral portion of the thigh. And same kind of thing where you're just stretching out the femoral nerve and sideline can be very beneficial for this condition. Okay, so sural nerve entrapment. What you can have is entrapment of the sural nerve as it, let me highlight here, entrapment of the sural nerve. Right there is a really common site. So the sural nerve is a cutaneous nerve and it goes down, supplies a lot of the tissue on the outside part of the lower leg and the ankle. And what you can have is entrapment as it passes through the gastroc area, and you can have vascular issues as well. But then the other entrapment and palpation site is right here behind the lateral malleolus. And I always like in hands-on classes when I'm able to work with people is palpating this, because this is like a very palpable nerve and it's right behind the lateral malleolus. But sometimes you'll strum that nerve and you can even elicit a bit of a numbness and tingling response on yourself. Okay, there's only a couple more nerves and then I'll get to if there's any questions. So prep some questions if you have them. So tarsal tunnel syndrome 1 we're very aware of, that's through the medial side. Tunnel's is a great test along this. So you're just tapping over the tarsal tunnel nerve. I'm doing it right now on myself and I'm getting a bit of that numbness tingling into the foot. Like, so if you just kind of palpate the medial malleolus, move a little bit posterior to that and tap along there and you might elicit some of that numbness tingling. But tarsal tunnel syndrome may overlap with some cases of plantar fasciitis where you'll have the medial or lateral plantar nerve entrapment, but always something that's worth looking into if somebody's having like plantar fasciitis symptoms or if there's numbness tingling, but it's only in the foot. Not touched on a lot, but I love these pictures. They're very easy to see. This so it's the, go back, it's the peroneal nerve, and what that can be referred to as anterior tarsal tunnel syndrome. So same thing, just like there's tunnels for the posterior part of the tarsal tunnel, for the anterior part, just tapping along that distribution, and you may elicit some of that numbness tingling. Where I've seen this a couple times is sports where people have like a rigid kind of footwear that they wear. Hockey players now, back when I played hockey, we had to hire boots for our skates, and now they're a much lower boot that has that point of pressure at a different spot in the ankle. And so sometimes people get, especially tying up the skates real tight, depending on their skating patterns, they may get irritation from the hockey boot. But football players can get it, soccer players can get it. Other sports where they're in a boot, kind of a rigid boot, like snowboarding, skiing, may get kind of irritation of this peroneal nerve. Morton's neuroma, I actually could not find a really good picture of this, but we think about just the squeeze test where we're just squeezing the metatarsals together and irritating that neuroma. But that helps confirm or kind of rule out if there is an entrapment of the nerve. Just working in kind of the metatarsals, doing joint mobilization, working the soft tissue of the foot can help benefit these patients because there's not a lot of great treatments with it. Sometimes they'll do steroid injections, surgery in the rare cases, but people often don't have great outcomes. So Massage is good for this. Use it within the patient's tolerance, but it's kind of like a good thing to work on as a massage therapist because there's not a lot of successful treatments, and massage can kind of just help manage symptoms. Okay, so really I want to summarize it up so I have time to go talk to you guys or go through a couple questions. But peripheral nerves can be exposed to irritants, whether it's an entrapment or inflammation at a number of anatomical points. So one of the best ways to figure out treatments is just to look at the peripheral nervous system again, see what muscles it innervates, see what area is the sensory portion, and then think about just even gently stretching, the skin, muscles, or the neurovascular structures can help activate endogenous pain modulating symptoms. That's going to help manage a lot of these peripheral nerve entrapments. And you always want to work that area to see if you can kind of like mobilize the nerve around to just kind of flush out that area, because the nerves have a bit of stretch to them, right? They're not these rigid structures. So by gently stretching and relaxing the nerve, you can help flush out some of that inflammation. Same thing with movement, as long as it's not provoking too many symptoms. Movement's one of the best things to help kind of flush out some inflammation. So you get good contraction of a muscle around that area, and it can help flush out the inflammation. Couple different references and resources I'll leave up for a minute of just where I got some of the content from. Okay, couple different resources I want to highlight. This was a really good research paper. One second. Let's go back. Okay, so this one was a really good research paper I came across, and it really highlighted a lot of peripheral nerve entrapments. Oh, right. This one's the research paper that highlighted a lot of peripheral nerve entrapments, and it really does summarize a lot of different areas where it can be entrapped. This one's really interesting because it talks about that neuroimmune response that happens with a lot of entrapments. Okay, so I'm going to stop sharing my screen. I'm going to go to the Zoom and see what we got for questions. Okay, no questions, but does anybody want to chime in?
Hi, good morning, Richard.
Morning, Francis.
Yes, hi. I'm actually just a student right now. I'm a term 2 student for RMT course. So I'm just trying to pick up courses where I can while I'm off. But I'm interested in learning about the nervous system directly. Like, we haven't learned the nervous system yet. So
yeah.
One of the questions that lingers with me is the atrophied muscles on the calf, so the gastrocs and the soleus muscles. For an atrophied muscle, is there any link between the nervous system for the calf muscles at all that we can activate those atrophied muscles?
Yeah, so atrophy, for sure, there is things you can do. So when you think about atrophy, that's going to be kind of the motor function to the nerve maybe has been interrupted, like the motor supply to the nerve. So there's lots of different reasons why that may go on. Some may not be able to be changed, right? But if it is like, say, a peripheral nerve entrapment, or even say it's a lumbar, like a true disc herniation where that spinal cord is being entrapped, there may be surgical interventions, and it's always worth consulting with a surgeon or having the patient consult with a surgeon to see if that's going to be the best case. But sometimes these, depends how long they were going on, I guess, is another thing. But even if it is like an entrapment, if that entrapment is kind of goes away, then you may get kind of some of that motor supply back and you can build up strength again. But I guess it always depends. It really depends on the case. It's so individualized.
Thank you very much for answering.
Yeah, no problem. It wasn't a great answer, but
that's okay. Thank you.
Yeah.
Thank you, Richard. Does anybody else have any more questions before Richard wraps up?
Yeah, I'm an ex-hockey player, and I struggle with a lot of pain in my feet. And I've always thought it was something other than related to my hockey skates. Can you talk about more, like I'm old school, like I grew up with metal blades, for Pete's sake. Can you talk about where the origins of this stuff is? For the tarsal entrapment.
Yeah, so anterior tarsal tunnel syndrome. So what that is entrapment of the deep peroneal nerve.
Okay.
And so you'll have the...
Could that be why the back of my calf is sore as well?
So the peroneal nerve is going to have supply that goes along the lateral side, right?
Yeah.
And so sometimes people have radiating symptoms as well, right? So we talk about that extraterritorial spread. So you have entrapment of the deep peroneal nerve. That distribution could be wide, right?
Yeah.
And so say people have true entrapment where scar tissue is built up along that nerve, right? So you might have chronic compression and just kind of symptoms going along with that. So yeah, it could always be like a posterior calf kind of thing where, and then you'll have, just.
I thought it was far more complicated than that.
It could be.
Well, no, I'm just like, you know, I've been feeling it my whole life, and I just thought, well, it is what it is, because my mom had bad feet, so I thought it was my feet. But then listening to that, I go, well, it makes perfect sense. But I've never really thought about it, because I used to tie my skate. I was like Paul Coffey, as tight as I could get and half a size too small, right?
Yeah, and that'd be a old school. That's even before me, but
old
school where people, especially footwear, hockey, there wasn't that stability in the boots, and people would just really tie it tight. And you look at people now, and you look at hockey skates, and these things are, I don't even know how these people stand up. I'd be bending my ankles, right? Like they're really loose fitting. People build a lot more strength, which is a really good thing in that foot and the ankle. But just,
it's just, okay, well, thanks. It's something I'm going to look at, try and get some help with, because I can work with that.
Yeah, awesome.
Thank you.
No problem. Actually, I did have some comments I missed. Notice anterior tarsal just. Richard, do you say? Okay, so where the slides will be posted. So I draw a blank on the name. LinkedIn, I think it has SlideShare, it's called. So what I'll do, I'll download the slides and put them on SlideShare. And so I think that's what you would Google. And so Google SlideShare Richard Lebert, and that should pop up, and that's where I've posted slides in the past. And I'll just download a copy, upload them into SlideShare, and then people can just download through there.
And if you send me the slides, Richard, I can also make it available for download off of our website.
Okay, yeah, I'll do that.
Okay, any other questions for Richard? Don't be shy. All right, we've got 10 more minutes left. So maybe at this point, Richard, if you want to share contact info for anyone who wants to take it down, you can also put it in the chat if you want, for anybody who might want to reach out to you after this.
Yeah, I can actually, one thing I can do, if it's fine with you guys, is show my ebook, and that has contact information, but it has a lot of supplementary resources. So it's a open access resource. It's free to download, free to use. You can order a print copy, and it's like $9 for black and white. Shipping, you got to pay like $9. But if you just want to download it yourself, you just download it and print it off. So I'll post a link too in the chat, but let me do a screen share. Okay, so what you can Google is called evidence-based massage therapy, a guide for clinical practice, and it should bring you to a page kind of like this. So what you can do is select whatever format. Say print PDF is probably one good if you're going to print it off, or digital PDF if you just want to read it. And then you click that, click download. If you want to order a print copy, order a print copy there. I don't make any money off it, so so don't think like, yeah, it's just for your own use, right? But here's a really good feature. So you say read online, and it brings you right to the ebook, and then you can stroll the different chapters. And there's a couple. Here's one page you can click on that has some nerve mobilization, more of my writing on nerve mobilizations, and under clinical examination, neurological examination. And what I've done is written a little bit about nerve entrapments, some more of the upper limb neurodynamic tests, lower limb neurodynamic tests, and then a synopsis of different nerve entrapments and the palpation sites along with it. Okay, lots of resources there. But there's tons of different chapters, and you can go over different musculoskeletal issues. So that'd be probably my best resource available for people to look up information.